A patient has a mechanical mitral valve, new AFib on top of it. Someone on the team suggests a DOAC because it's easier for the patient. That decision alone can kill someone. Mechanical valves are one of the few absolute DOAC contraindications in all of pharmacy. And that's not a rare mix-up. It's one of the most common medication errors in valve patients. I'm Dr. Anderson. This is Note to Pharm.D, and today we're covering anticoagulation and valvular heart disease, bioprosthetic versus mechanical, and exactly where the AFib-only rules from the last video stop applying. 2 buckets today. Bioprosthetic valves, where aspirin is often enough and DOAC actually have a role, and mechanical valves, where warfarin is non-negotiable and INR targets shift depending on position and risk factors. This is the nuance that trips people up the most in this whole anticoag world. Let's start with bioprosthetic valves. The first 3 months after implantation are the highest risk window for thromboembolism, and that risk is meaningfully higher for mitral position valves than aortic, simply because mitral flow is slower and the valve orifice is larger. Default therapy is lifelong low-dose aspirin, absent another indication for anticoagulation. If the patient's at low bleeding risk, you can add warfarin targeting an INR of 2.5 plus or minus 0.5 for 3 to 6 months instead. That's a reasonable alternative, not a requirement. Now here's where it gets interesting. Concomitant AFib. If the valve was placed more than 3 months ago, a DOAC is a perfectly acceptable alternative to warfarin, dosed off the patient's CHADS-2 VAS score, just like we covered last video. But if AFib onset is within 3 months of valve placement, warfarin is the answer. No DOAC substitution in that window. A few numbers to anchor this. Valve disease carries a 20-fold higher thromboembolism risk compared to no valve disease at all. The INR target for a surgical bioprosthetic valve is 2.5 plus or minus 0.5, and that initial warfarin coverage tops out at 6 months before you reassess. Practice pearl here. Don't confuse bioprosthetic with low maintenance. The 3-month window right after implantation is genuinely high risk, and that's exactly when patients are transitioning out of the hospital and most likely to have a gap in follow-up. If you're doing discharge counseling on one of these patients, that timing conversation is worth the extra 2 minutes. This is exactly what the River trial tested. Historically, patients with AFib and a bioprosthetic mitral valve just got warfarin by default. Nobody had good data on whether a DOAC was even reasonable there. River put rivaroxaban head-to-head against warfarin in this exact population, over 1,000 patients, and the result wasn't just non-inferiority. Rivaroxaban actually came out ahead on both stroke and major bleeding. And here's the detail that really matters clinically. The benefit was even larger in the subgroup enrolled within 3 months of valve placement, precisely the window guidelines have traditionally reserved for warfarin alone. The quote to hold on to: thrombotic events or cardiovascular death were significantly reduced with rivaroxaban compared with warfarin in patients enrolled within 3 months of valve placement. That's genuinely practice-informing data, even if it hasn't fully rewritten the guidelines yet. Worth noting the numbers behind that headline too. Stroke specifically was significantly lower with rivaroxaban at 0.6% versus 2.4% with warfarin. Major bleeding followed the same pattern, 1.4% versus 2.6%. This is a single trial, so it shouldn't be read as a guideline override, but it's exactly the kind of data that should make you comfortable having the DOAC conversation with the cardiology team when the patient profile fits. Now let's flip to mechanical valves, where the rules get much stricter. Warfarin only, no exceptions, regardless of valve position. This is a Class 1 recommendation, and DOACs have zero role here. Full stop. INR targets depend on position and risk factors. Aortic valve, no additional risk factors, target 2.5 plus or minus 0.5. Aortic valve with risk factors like AFib or prior thromboembolism, any mitral valve, or an older generation valve like a ball and cage design, target 3.0 plus or minus 0.5. And bridging is genuinely procedure dependent, not a blanket rule. A patient with a bileaflet aortic valve and no other TE risk factors having a temporary interruption for a procedure doesn't need bridging at all, while the INR is subtherapeutic. The thrombotic risk during a brief interruption is low enough that bridging just adds bleeding risk without benefit. Key numbers here. 3.0 is your target INR for a mechanical mitral valve. 5 days is the minimum injectable bridge duration after valve placement itself. And 0, that's how many DOACs are approved for any mechanical valve position. Here's a scenario worth having ready. A patient with a mechanical mitral valve comes in for a routine dental extraction. Bleeding here is easily controlled locally, so the answer is simple. Continue warfarin at therapeutic INR straight through the procedure. No holding, no bridging. That's a genuinely common question from dental offices, and it's an easy one to get right once you know the rule. So why isn't bridging one size fits all? The 2020 ACC/AHA valve guidelines actually split this decision by both valve type and personal risk factors, and that split matters. A patient with a bileaflet aortic valve and no other risk factors tolerates a subtherapeutic INR just fine during a procedure. Bridging there adds bleeding risk with no matching benefit. Flip that around, older generation valve, mitral position, additional risk factors like prior TE or AFib, and the calculus reverses. Now the thrombotic risk during interruption outweighs the procedural bleeding risk, and bridging becomes the reasonable choice. The direct guideline language. For a bileaflet mechanical aortic valve with no other risk factors for TE, no bridging is needed while the INR is subtherapeutic. Notice what it doesn't say. It doesn't say no bridging ever. It's conditional, and that condition is exactly what you need to check before making the call. 3 things to remember. 1. Bioprosthetic valves default to lifelong low-dose aspirin. Mechanical valves default to lifelong warfarin with 0 DOAC exceptions. 2. INR target scale with thrombotic risk. 2.5 for a low-risk aortic mechanical valve, 3.0 for a mitral position or added risk factors. And 3. Bridging decisions hinge on valve type plus personal risk factors, not a universal rule. Weigh bleeding risk against thrombotic risk for a specific patient in front of you. That covers valvular heart disease. Next time, we're moving into prevention of VTE, how to actually risk stratify surgical and medical patients for prophylaxis. If you found this useful, like the video, leave your questions in the comments, and subscribe so you catch the rest of the series. I'll see you in the next one.